Hello and welcome back to the channel. Today we're going to cover acute lymphoblastic leukemia, or ALL, one of the most important hematological malignancies that you must know for exams like NEET PG, NEET, and also for clinical practice. Let's break it down step by step. Acute lymphoblastic leukemia is a malignant disorder of lymphoid progenitor cells. It is the most common childhood malignancy, but it can also occur in adults. It's characterized by uncontrolled proliferation of lymphoblasts in the bone marrow, leading to bone marrow failure and infiltration of various organs. Let's begin with etiology. Children with Down syndrome, or trisomy 21, are at a significantly higher risk of developing ALL. Similarly, children with inherited disorders, such as ataxia-telangiectasia, are predisposed. There is some evidence of environmental exposures like pesticides and certain chemical agents playing a role, but in most cases, no definite causative factor is identified. Now, moving on to signs and symptoms. Most of the clinical presentation is due to bone marrow replacement by leukemia cells. Patients commonly present with fatigue, recurrent infections, fever, easy bruising, or bleeding because of anemia, Neutropenia, and Thrombocytopenia. Other symptoms arise from bulk disease, for example, Lymphadenopathy, Hepatosplenomegaly, or bone pain. In rare cases, patients may develop shortness of breath due to leukostasis or a mediastinal mass, particularly in T-cell ALL. About 3 to 5% of patients present with central nervous system involvement, headache, confusion, cranial nerve palsy, or rarely orbital involvement. On physical examination, you may see pallor, tachycardia, petechiae, ecchymosis, fever, lymphadenopathy, hepatosplenomegaly, and sometimes pleural or pericardial effusion. Gestacular involvement occurs in about 2% of male children, particularly in T-cell ALL or those with very high leukocyte counts. Hence, a careful testicular exam is important. Don't forget a baseline neurological exam, since CNS involvement is clinically significant. Now let's talk about investigations. A peripheral blood smear usually shows circulating lymphoblasts, decreased platelets, and absence of mature normal cells. Morphologically, lymphoblasts have condensed nuclear chromatin, high nuclear to cytoplasmic ratio, and usually lack Auer rods. Classification today is mainly immunophenotypic and genetic. Precursor B-cell ALL expresses CD19, CD79A, or CD22. Subsets include Pro-B, common ALL with CD10, and Pre-B with cytoplasmic IgM. Mature B-cell ALL corresponds to Burkitt leukemia with surface IgM positivity and vacuolated cytoplasm. T-cell ALL shows expression of CD3, CD7, CD5, and other T-cell markers. Bone marrow aspiration is mandatory. It shows hypercellularity with more than 20% blasts. Cytochemical stains such as PAS positivity and terminal deoxynucleotide transferase, or TDT positivity, support the diagnosis. Flow cytometry, cytogenetics, and molecular studies are essential for classification and risk stratification. Other baseline investigations include CBC, coagulation profile, renal and liver function, uric acid, calcium, phosphate, magnesium, and HLA typing for possible transplantation. A chest X-ray is important to detect mediastinal masses. Lumbar puncture is required to evaluate CNS disease, but in unstable patients it is usually delayed until systemic therapy begins. Cardiac evaluation with ECG and ejection fraction should also be done before chemotherapy. Now, what about the differential diagnosis? Reactive lymphocytosis due to infections like mononucleosis or pertussis, acute myeloid leukemia, leukemic transformation of CLL or myelodysplasia, mantle cell lymphoma, and plasmablastic myeloma must all be considered. Let's move to management. First, stabilize the patient. treat complications of marrow failure with blood and platelet transfusions, and treat infections aggressively with antibiotics. Tumor lysis prevention is very important. Hydrate the patient well and give allopurinol or rasburicase for hyperuricemia. Central venous access is often required. Prophylactic antibiotics, antivirals, and antifungals are used in neutropenic patients, and pneumocystis prophylaxis is recommended after the second cycle of chemotherapy. Now comes the backbone of therapy: risk-adapted multi-agent chemotherapy. Prognostic features include age, white blood cell count at presentation, cytogenetics, time to remission, and minimal residual disease status. Infants below 1 year and adults above 60 have poorer outcomes. WBC count more than 50,000. Philadelphia chromosome positivity, T2922. MLL rearrangements, or hypodiploidy confer poor prognosis. On the other hand, hypodiploidy and T1221 with TEL-AML1 fusion carry favorable prognosis. Induction therapy combines vincristine, prednisone, asparaginase, cyclophosphamide, and anthracycline to achieve complete remission. Consolidation and CNS-directed therapy are essential, including intrathecal methotrexate, cytarabine, and sometimes cranial irradiation for CNS prophylaxis. Intensification or delayed intensification phase includes high-dose methotrexate, cytarabine, cyclophosphamide, and other chemotherapy drugs to strengthen treatment. Maintenance therapy involves using mercaptopurine, methotrexate, vincristine, and steroids over 2 to 3 years to maintain remission and prevent relapse. Special situations include Philadelphia-positive ALL patients benefiting from tyrosine kinase inhibitors like imatinib, alongside chemotherapy and allogeneic stem cell transplants for high-risk cases. Treatment toxicities are common, including mucositis, infection, bleeding, hepatotoxicity, pancreatitis from asparaginase, and cardiotoxicity from anthracyclines, requiring close monitoring. Prognosis varies, with over 90% remission and 70% plus long-term survival in children, while adults have 70 to 90% remission, but only 25 to 50% long-term survival, with relapse as a major cause. Long-term survivors may face neurotoxicity from CNS prophylaxis, organ damage from chemotherapy, immunosuppression, or secondary malignancies, highlighting the need for ongoing care. Acute lymphoblastic leukemia is a malignant disorder requiring detailed diagnostics and risk-adapted, multi-phased management, including supportive care, tumor lysis prevention, CNS prophylaxis, and maintenance therapy. If you found this video useful, don't forget to hit the like button, share it with your friends, and subscribe to the channel for more high-yield medical content. See you in the next video.